For everyone with an interest in NASH, or more broadly, fatty liver disease, Surf's Up, Season 3, Episode 62 of Surfing the NASH Tsunami. The second of our 3 special year-end wrap-up episodes starts now.
This week on Surfing the NASH Tsunami.
There are many things that excite you in life, and in science, I keep going with joy when I try to contribute, lead to something that will change the field moving forward.
A decade of work has come together, and I think 2023, with those tools, with the increase in awareness by a number of key organizations, and hopefully phase 3 trials, finally we're making real objective progress.
You're not doing anyone, patients or people at risk, a service if you're not also mentioning the role of liver health. You're not providing full and good care for people with diabetes if they're not aware that they're at risk of and actually have a very high likelihood of having liver fibrosis.
As an exciting 2022 comes to an end, Surfing the NASH Tsunami looks back on some of the year's key advances. Join hepatology researcher and key opinion leader, Professor Jörn Schattenberg, liver wellness advocate Louise Campbell, pricing and forecasting guru Roger Green, and our guests, hepatology researcher and key opinion leader Dr. Mazen Noureddin, endocrinology researcher and key opinion leader Dr. Ken Cusi, and public health researcher and key opinion leader Jeff Lazarus, as they consider the year's key gains in knowledge, commercialization, and advocacy on this special year-end edition of Surfing the NASH Tsunami.
It's Roger Green. Welcome to our second round of 2022 wrap-up interviews. The format's the same one we initiated in 2020 and used again last year. This episode will include sections of interviews with 3 of the people who made headlines and advances in fatty liver disease in 2022. Each conversation, released tomorrow or Wednesday, will provide one of those episodes in full. This episode includes 3 of our favorite guests, people with extremely diverse perspectives on fatty liver disease. First, Mazen Noureddin joins us to discuss some of the reasons he considers 2022 such a promising year in terms of drug and diagnostic discovery and research, and predicts a powerful and optimistic period all the way through to 2026. Ken Cusi discusses the adoption of fairly parallel guidelines by several of the major medical societies in the U.S. and how that came about. And we all discuss how 2023 is likely to feature bold new efforts to educate frontline diabetes treaters and clinical hepatologists about best practices in using these guidelines, as well as the medications and new tests that are driving NASH therapy forward. Finally, Jeff Lazarus joins us to discuss the worldwide momentum to focus more attention on fatty liver disease, areas where we need greater energy and attention in the year ahead, and what the impact of the nomenclature process might be. Not the name, just the impact. Louise, Jörn, and I had fun conducting all these interviews. Hope you'll have fun listening. But by the way, there'll be no business report today. Instead, Grace will be back after these discussions with a preview of our year's final set of interviews coming on Thursday. So, with that, I'm off for the day. Thanks to the crew, Jake and Magic Mike, who worked through Christmas Eve to make sure we had the posts for you today, tomorrow, and Wednesday, and Eric and Steve for all you do every day. Until our final episode of the year on Thursday, stay safe, surf on. We'll see you on the podcast. Bye-bye now.
First, the surfers talk with Mazen Noureddin about a productive year in fatty liver research and readouts, and the future of NASH drugs and non-invasive testing.
Mazen, you've had a busier last 12 months than most people. You mentioned briefly the Research Institute. You started the year in LA and you wound up in Houston and a whole bunch of other stuff. Tell us a little bit about your year, your amazingly productive and eventful year.
Yeah, it started with multiple reasons. A good opportunity to build a research institute, family reasons, and personal reasons, which is very much trying to focus and balance a little bit and get healthier. So the year started between February and May. There was a big transition where I don't want to get too personal life, but I sold a house, I bought a house, I was back and forth between California and Texas. And then I started looking into the future here in Houston, Texas, which, as you know, it's a fantastic medical city. It has the biggest medical center in the world between Baylor, Houston Methodist, and University of Texas, which has MD Anderson in it. And I moved here and I'm wearing 2 hats right now, a private work, which is my research institute, Institute as well as academic work through the Houston Methodist Hospital, which I chose because it's a very equivalent and a similar system to Cedars-Sinai, where I came from. Similar reputation, similar clinical capacity and outcomes. Indeed, that they do very well in liver transplantation, and they're now number 2. At the same time, my excitement has been in the Houston Research Institute, which is still in infancy, but we are preparing for a really large setting with 10,000 to a square foot, with the opportunity expected for 10,000 that will do not just clinical trial, it will do translational medicine and clinical trials. So the academic component will be there. We're going to do phase 1 through phase 3 hepatic impairment studies, but we also have a storage unit that will include 6 -80 freezers, data management where we'll collect samples, and the nail NIT biobanking actually will happen in the Houston Research Institute, which that's part of the scientific excitement that I'm happy to talk about. So a lot to going on. My life is centered definitely around my 2 girls, Naya and Lily. Naya is 4. She found a great place here. You guys know that my wife is Belgian, so they speak, I don't. They speak French at the house, and we found her a school that she can speak a day French and day English, which she's quite enjoying. And my wife, meaning her Franco people, which I think Franco people, they're excited to meet each other and speak French with each other. And the little one, we started before 1 year old, we said that she has her mother personality, which is a good thing. And then once she started walking, it's like she now owns the world, and now she has my personality, which according to my wife is not a good thing. So, thank you for having me here. It's an honor, it's a privilege, and I continue to make friends in the field, and that's what I really enjoy, having people like you, Roger, Louise, and Jörn, and many others that I can count, and I had many meals with them, and I continue to collaborate in science with them.
So, and then Mazen, I guess the other thing that you did this year is kind of fantastic, is you got yourself in a much better shape, right? You dropped some weight. You look wonderful.
Well, thank you. I did drop multiple sizes, and BMI turned from being not good, so I don't say to what it is, to not a normal, but not too far.
Close enough. You should know, by the way, that we've already had a Matt Damon reference this week for Jörn.
I'm not going to lean on him tonight.
With all that going on, and everything you've been doing this year, you can walk us through, if you'd like, nail NIT or some of your work in other diagnostics, or something you've done this year that you'd really like to spend some time pouring into with us.
Let me start with the fact that I've been blessed to have a good year this year, and I really want to highlight that because I say it genuinely, it would have not happened without the collaboration, the good people I worked with. So starting from amazing people, that my resident Emily Trong, who has published quite a bit this year, and you just give her a project and she will go with it. And I was very happy to hear that she matched in her first choice, which I did not interfere in, which was my previous institute, Cedars-Sinai. Another unbelievably productive person is Cheng Han Nag from Singapore, who I've worked with him very closely, he and Mark Mathia, on multiple projects. And that group, we did multiple studies with Arun Sanyal and Shadab Siddiqui from VCU. I've worked with Naeem Al-Khoury, Jörn Schattenberg, Stephen Harrison, many others. I really don't want to miss any. So there are many things that excite you in life. And in science, I keep going with joy when I try to contribute and just not necessarily produce a large number of paper, or not necessarily high impact. High impact is important, but also high impact that will lead to something that will change the field moving forward. And maybe I see it in clinic one day and make sure it happens. So I think the biggest 4 things for me that they come across mind immediately is, 1, the MRI score, the mass score that we published in JHEP. I can talk about that quite a bit, but I don't want to bore you with it. But I'm also glad to see now newer data from other groups showing how small is the indeterminate zone with that score, and how well it does with correct classification. And I can talk about that more. I also want to mention Devin Chang, and which I forgot to mention, who's a high school student that came to work with me. And I asked a professor of biostat at UCLA if he knows how to do machine learning. And it turned that, I shouldn't say that kid, but that kid, he's in high school, does amazing work with machine learning. And he came up with a model that predicted F2, F3, F4 NASH and F2 and higher very precisely. And we published that in Hepatology. So that was another excitement. And another excitement is just happened recently is a new mechanism of action that I worked with Arun Sanyal and one of the companies on, which is H26, which is mitochondrial uncoupling. You don't see it in the reviews for pathways of NASH. So this is a new mechanism with potential fat oxidation in the body as well in the liver that we're preparing for publication. But as you know, like Litmus Nimble and many others are trying to move away from liver biopsy, and we started seeing movement in that big rock started shifting a little bit. And I think what is being looked at now, a retrospective and prospective analysis looking at correlation with NITs and outcomes. And I'm honored to starting this and collaborating with many people, including Stephen Harrison, Jörn Schattenberg, Naima Khoury. I don't want to miss other people. There are people from pharma as well, the CEO of Terns, Amy Articolo from Novo, Donna Cryer, the Summit Clinical Research Work, and President Gail Hickson, as well as the CMO, Sophie Janine, and many others. We have really like the many world experts, collaborators on this. And one of the good news is that, which we probably should announce soon, that we started getting funding from big pharmaceutical companies that they approved us for funding. And I can see the appetite for big players in the field that they want to move away and quickly with a field without a liver biopsy.
Congratulations, Mazen. That's an amazing list also for the collaborations. And I mean, you're really one of the key people in the field at this time. I think I can say I'm very happy to do some of the work you've been doing with you. Let me pick a little bit on you about the drug development, because really the HU, 6 presentation you gave at AASLD was very interesting to me. I found it was well presented and it was an interesting set of data. My question to you is, do you see more of those mechanisms that might have been trialed like in obesity or some metabolic disease spill over into hepatology again? And is this something where you see the interest in the drug development arena in hepatology, particularly in NASH, is increasing? You know, we were seeing maybe some ressentiments over the last years, and now you're coming up with a total new MOA or maybe newly reintroduced to hepatology. Do you see a shift here, or what's your perspective on that?
I don't know if it's quite a shift rather than add-on and innovation kind of pushing the boundaries. When I say innovation, mitochondrial anti-couplers have been around for many years. And as you know, they had previously some side effects issues when the drug was not FDA regulated. So with this company coming and doing it correctly in terms of pharmacokinetics and pharmacodynamics, the MOA worked well without causing side effects. In terms of your question of the weight loss drug is going to spill over to NASH, that is an expected path because, as you know, this is a multi-systemic disease with obesity, diabetes, and dyslipidemia being partners with non-alcoholic fatty liver disease in affecting patients' body. Thus, losing the weight and improving insulin resistance will be the core and the management. There are a few things also with the weight loss medications. As you know, some of the weight loss medications, they have systemic effect, and some of them, they have systemic and liver effects, such as the GLP-1 and glucagon duals. And the duals are probably more attractive because they affect the liver as well, and they might affect, or they do affect the mitochondrial oxidation and hopefully fibrosis eventually. And I mean, even the systemic one, the GLP-1 alone, as you know, weight loss drive everything the right direction, including fibrosis. We still are waiting to see. With that drug, the mitochondrial uncoupling, it was kind of like proof of concept study in a randomized placebo-controlled trial fashion, which was 61 days only. And I can tell you, like, overall 30% reduction was up to 70% in the higher two doses. But when you looked at those that they are metabolically disadvantaged, and here we define it as A1C abnormal, it reached up to 86% for 30% reduction within 61 days only. So that's very promising. But here's the important things, which is pushing boundary and pushing the envelope. Weight loss or rapid weight loss or very efficient weight loss, there's a story of causing sarcopenia or frailty or losing muscle effect. And that study, one of the things that we showed that we did not lose muscle, rather it was body fat. And this is where I'm calling for, or I'm proposing here with the weight loss medications, no matter what's the mechanism of action, there are three things that needs to be, or four things to me, now it must be reported. One, are they oral injectable? 2, side effects profile with special emphasis on nausea and vomiting. And if you start having mitochondrial uncouplers and stuff like that, you want to see like heat and cardiac effects and all that. The last 2 are really important, which is, do they affect fibrosis or not? They're going to affect fat and NASH, and I think eventually fibrosis. But the question is, do they really affect it and how long? And we have seen all of the above reported, but I think as experts or researchers in the field, we also have to ask for data on muscle loss and sarcopenia, especially if we're going to use the drugs eventually in cirrhotics. As you know, they have sarcopenia and obesity sarcopenia. So that's how I'm looking at those weight loss drugs.
It's interesting because there were 3 people who were going to be part of our coverage at AASLD who didn't make it either. I think in 2 cases got sick. I don't remember what the third one was, but all 3 of them wanted to talk about your HU6 paper. They were tremendously excited about it for the reasons you just talked about, and felt that it might ultimately be advantaged against the glucagon agents because it didn't have the side effects or safety issues that you just described that went along with rapid weight loss. Louise, I kind of feel like we're in your neighborhood when we're talking about metabolics and multi-metabolic health issues.
All of the work that Mazen's described is fantastic work over the year. We spoke with Hannes Hagström earlier, and he was reflecting at one stage on how young, in some respects from the data set, we're now seeing NAFLD. If we only focus on your NALNIT program, if we only focus on fibrosis, are we waiting and letting these patients develop NASH before we actually are going to step in the younger generation? Or is that going to be the strength of NALNIT? It's going to pick up NAFLD in younger populations, which give us an opportunity to prevent NASH. My second question or observation was, I'm now seeing more and more people who take semaglutide for weight loss coming in for FibroScans, which, to be fair, so far have been normal after a while. So is that the type of metabolic medication you're looking at trying to get more data off? Because, of course, that's in the real world now, and we're missing data sets from the populations because they're not being screened. So I know that's a few questions in there.
Yeah, so I might have to ask a little bit more details on question number 2, but for question number 1, and let me first praise you for your leadership in the field and talking about preventative medicine and screening and all this, which, as you know, I have worked on that, and one of the things I really wanted to get out of the field, if screening is quite effective, and we wrote that paper in Gastro in 2020, that I was humbled and happy to see the AGA pathway quoting it as the cost-effective analysis paper. So that's the win. I feel like as researchers, we push the field and help our patients. But for the NALNIT, actually, there's a different goal and different message. Not more important, the screening and prevention is as important. The goal of the NALNIT, and I'll summarize it in a second, and I will give an exciting announcement of now what it's developed to. And Jörn, I probably mentioned it to you or not yet, and since the scientific steering committee met. So then NALNIT will do a lot of retrospective analysis that Jörn Schattenberg as well Naim Al-Khouri are leading to fill many gaps in the field. The part B, which I think will answer your question, is which targeted population we're looking for. I think we want to assist other consortium with probably the first consortium that is statistically designed and planned to look at outcomes. So no fibrosis, because as you know, it's a surrogate of outcomes in liver disease. We're recruiting the top candidates NITs, especially if they show in retrospective or small cohort data or pooled analysis that they have some correlation with outcomes. And what we're really going to do is to answer that question, or the famous question or request by the FDA and EMA, which is, I want you to show me that if your NIT or combination of NIT, if they worsen, they predict outcome reasonably, which we have some data, but we're going to do it in prospective large trial design. And more importantly, and this is the most recent update we have, we are going to show that changes in non-invasive testing, meaning their improvement lead to improvement to outcomes. So Jörn, what has been updated, but we still have to finalize it since our scientific committee meeting that included many or really amazing KOLs in the field, the update that we are shortening the term of the study. We felt that there is a need to get this study done within 2 and 2.5 years. We met with many biostatisticians that worked with the FDA and EMA, and now we're targeting that 2.5 duration to get the answer. So in contrast to prevention and screening, Louise, we are going to focus on the group that have morbidity and outcomes, which is F3 and F4, and we're going to have F2s as well. But we want to reach the outcomes with a reasonable time and show what we show. And if the FDA has any doubt that a trial can be designed based on NITs. We will solidify that answer and make sure in 2025 or 6 we have a trial that is designed based on NIT. And when I say trial designed based on NIT, I'm talking about phase 3 registry, even if it's going to be subpart H, but they should go with it. If it happens before that, because I'm hearing some positive signal from the regulators, let it be. Though the positive signal, we are hearing that we need such a data that the NILT designed for. And that's why my new 2 updates in the last 6 months, I know we talked about it multiple times, is a shorter trial design that they will get many newcomers to phase 2B and phase 3, a good background and evidence-based medicine that they can use this nail NIT. And because of that, we have seen, or we have which I cannot share yet until we sign the papers, that now we have good approval or final meeting approval from 2-3 big pharma companies. So we're moving forward.
That, to be fair, is really exciting. We see it in practice. We see it in our clinics. We see people regularly monitored with non-invasive technologies, whether it's FibroScan, whether it's MRE, whether it's CT. We see them improve, but we only focus on the ones when we look at outcomes for fibrosis and the ones who deteriorate. We don't actually record very well all of those patients. We get better, we improve their liver conditions, and then we see them less frequently in clinic. So it sounds very exciting, and I'm waiting to see all of that because we see it.
Mazen, for one thing, it should be noted that earlier in the year when we were asking lots of folks how quickly we might get beyond the biopsy, you were a year to 2 years more aggressive than anybody else. And I think your outside window was 2026, and you're now saying you might actually be faster than that.
I think we're not the only one that are thinking that way or hoping to go that way. I think the Madrigal cirrhosis trial also has designed their trial based on a shorter duration. So we probably will be done around the same time, or us first, but you will have large data set from NASH cirrhosis trial. Hopefully the drug will work on that population there, but ours will be natural history with many NITs and inclusive. So there is a movement now. It's like, guys, let's move. And enough 8 out of 10 screening failures and enough doing liver biopsies that we don't do anyways in our clinical practice. I mean, neither me or Dr. Schattenberg will use liver biopsy often anymore. I could be wrong, but you like biopsy, Dr. Schattenberg?
It's gone down significantly. We're talking to students about a research project, and I was worried I don't get enough biopsies to support this. It's clearly gone down, and most of it is in clinical trials.
And I believe liver biopsy in Germany, I could be wrong, remains a laparoscopic liver biopsy?
It's a little something special that some German centers do, where we do call it a small laparoscopic procedure and actually look at the liver and biopsy it. It allows for more passes, and you can actually stop the bleeding. We probably do it more still than other centers, but it's significantly gone down. But I mean, this is one great example of how the field's really moving forward, and Mazen, for that, thank you for sharing all that new development on nail NIT. And I think you're right, it augments the field. I mean, this is not a standalone consortium. There are a lot of them are asking different questions, and I think by combining those questions across the different consortia, it's really moving the field. And as you said, nail NIT probably has the largest analysis plan for asking the question on the outcome and replacing that surrogate of liver histology. So congratulations.
Thank you, sir.
Yeah, it does have the potential to change virtually every commercial rule that matters, right? I mean, if you can get the screen fail rates down and you can shorten the studies, first of all, shorten the time to get biopsy out of the picture, and then in the process, get the screen fail rates down and provide data that will be more practically valuable to doctors when they then have to take new drugs into practice. You've managed to shorten the time to approval and probably shorten the time to uptake after approval all at once, which is pretty heroic, a word I don't use very much.
That's great. We're fortunate now to have many imagings and other non-invasive testing, FibroScan, PDFF, MRE, price is a different story, ELF, and other biomarkers. We are working on other biomarkers, like that's going to come hopefully in this coming year on metabolomics. But also, I mean, I think Jörn had one of the very first publication in machine learning. We had a paper in machine learning, and I just saw Alina Allen presenting in ASLD a very good data. And I think Ray Kim, our incoming ASLD president, has also published in hepatology and machine learning. So how cool it is that now, like, you can go data mined Epic using the US largely and just discover all your F2, F3s, and F4s and NASH and F2. And indeed, in the future, will be apps to manage NASH. And we know of some of them, and I don't want to turn this into a commercial thing, but there are a lot of apps now being used, and they're looking into using smart platforms in addition to imaging and stuff like that. So we're moving very technologically savvy.
Next, Ken Cusi joins the surfers to discuss 2022's remarkable progress in aligning professional societies around guidelines and pathways. and to discuss new initiatives to educate frontline treaters in 2023, including Surfing NASH's continuation of the Rising Tide in Diabetes series.
It's been a wonderful year, and again, the effort of many, many people in the field of NASH over years, we have tried to crystallize the effort of increasing awareness, and a lot of effort of many people that participated in these guidelines, we were able to end 2022 with consistent guidelines that will help moving forward, prepare the field for the drugs that are under development, and also for highlighting the importance of early diagnosis. And we'll talk more about that. But I think it's like pushing a rock to the edge until you get it over. And I think finally a decade of work has come together. And I think 2023, with those tools, with the increasing awareness by a number of key organizations, and hopefully phase 3 trials that are very exciting, and a lot of, to-be studies. I mean, I think finally we're making real objective progress.
Fantastic. So I want to go back in a second and talk about, as you said, early diagnosis and the idea that these guidelines are converging around the same topic. But just a question I'm curious about, what has been the magic? You said you've worked on this for a decade, and this is the year it all came together. What made 2022 the magic year, or is it just serendipity?
Well, it's always a bit of both, but I believe the field expanded to true appreciation that this is a problem that needs to move out of the liver field to the trenches of non-hepatologists. That thought was always there, but really never materialized into real progress. I remember the guidelines you wrote a decade ago for ASLD, and then in 2018, there was hesitancy about, call it case finding in high-risk groups or screening, either way. And I think that has changed with the building evidence that people, particularly with type 2 diabetes and obesity, should be screened with some inexpensive tool. And I think that has turned into really a focus on going out of the liver field into the trenches, as I like to call it, to primary care, endocrinologists. That's going to make real difference. And again, I've been advocating. I remember I first wrote that we had to screen people with type 2 diabetes in the same way that we do people with diabetes for chronic kidney disease, for eye complications. And I hope I had some contribution in this evolution of thought, but there's now a broad consensus to do this.
A lot less lonely, huh? A lot more allies and colleagues from different places.
Yeah. Well, I heard that if you reach your dreams in your lifetime, you didn't dream big enough. But sometimes you see things happening, We just have to put in the homework, focus on what you think is important, and then it's not in your hands that things will turn out the way you want. Sometimes you get lucky and see the fruits of your labor, and others you don't. But this is the fruit, again, of many, many people. Louise has done a fantastic job where she is, each one of them adding to the greater good.
Now let's go back to the points of convergence, right? That we're talking about a common sense of screening and pushing out to frontline treaters, primary care, endocrinology. First of all, please, just for those who don't know, explain what's in the guidelines that addresses those sets of issues and how they fall out.
Yeah, I think one big step was the American Gastroenterological Association, AGA's 2021 effort that started in 2020 when Dr. Campbell came to me and a primary care doctor called Jay Shubrook to put it together key opinion leaders, not only from the liver field that were still an important majority, but primary care, endocrinologists. I enrolled the American Diabetes Association, the Obesity Society, Endocrine Society, the American Association of Clinical Endocrinologists, and other relevant liver and primary. And then we came up with a framework that was published in 4 journals: the Obesity Society Journal, which is Obesity; Diabetes Care, which is the official journal, clinical journal of the American Diabetes Association; Gastroenterology, as you know, and Metabolism. And it was supposed to be a 2-day meeting. Then COVID made it complicated, so we did it virtually. But we came up with some common ideas and knowledge gaps. And the idea that was how to identify with a low cost approach, because we don't have a lot of long-term cost effectiveness for more expensive tests. But the FIB4, which this group knows, or if others outside of liver field don't know, it's just an index that comes from age, liver enzymes, plasma aminotransferases, ALT, AST, and ALT, and platelets. And this gives you an index that, if it's high, can tell you that we need to do additional testing, or you're at high risk of advanced liver fibrosis. So that simple tool, which is not fantastic, but it's a starting point, had two purposes. A, develop a muscle for identifying people in these three high risk groups: people with type 2 diabetes, people with obesity, particularly if they had risk factor, cardiometabolic risk factors, and people with elevated liver enzymes or steatosis by any incidental imaging. So three high risk groups, a simple test, and then a second test, which in this case was imaging. And again, highlight the importance of multidisciplinary teams, a lot of the work Louise does. And then this was followed, I think, by another important guideline that started also in 2020, but materialized just 2 years later for a number of reasons: the American Association of Clinical Endocrinologists guideline that I accepted to co-chair with Dr. Isaacs from Atlanta, not to make another guideline, but just to develop more in depth what endocrinologists and primary care should do. So we, with the same framework and same guidelines, we just put more flesh on the bone and explain and address key issues. But the guidelines are basically the only difference. They added proprietary test called ELF that this liver audience, the pathologists are very familiar with, to add in the case you didn't have FibroScan. And this is co-sponsored by the American Association for the Study of Liver Disease, particularly Dr. Iannuzzi and Dr. Rinella, Dr. Voss, because we also had a pediatric section. And I think this is also very important, and we made it very simple. And then the AASLD, as you know, in the last meeting in November, updated their guidelines, and they're very well aligned with this. And I've been working with the American Diabetes Association that also in January are going to have a greatly expanded section on fatty liver disease, and we're going to be gathering very soon to spell out very clear recommendations that are going to be pre-aligned with this. So all these associations are now giving the same message and getting the field ready for action. And action, I have to say, the reason for screening is because we can do things today with nutritional counseling that induces weight loss, with bariatric surgery, and with some medications for obesity or diabetes like semaglutide in the very important study that was published in 2021, or pioglitazone from several studies.
So, you're preaching Louise's language, and by that I don't mean that we all speak different forms of English. I'm kind of talking about liver health and early screen and all that. Louise, why don't you take the next question? I have a couple of things I want to ask Ken about, but why don't you go ahead first?
I've left mainstream health to try and push this early awareness of liver, but actually for people to own their own liver health. Because actually, why at the moment the default is knowing about your liver when you've got disease, and actually knowing about your liver before you get disease, just when it's in a poor healthy state, is probably key for me. And I think Ken is absolutely correct in my book. If I just look at my recent experience in Australia, I only needed to scan 3 people to find fatty liver, but I only needed to screen 19 to find significant fibrosis. So where do we say that the numbers that we need to find stop screening being a positive tool when we look at fat in the liver being a poor health? Yes, some of them already had associated metabolic conditions, but I think Ken's comments on the FIB4, recently I think it was the Schmidt Heart Institute at Cedars-Sinai have just come out looking at FIB4 being when it was high, conferring a 4-fold increase in heart disease. So is the FIB4 may not be the best tool, but it's certainly getting some buy-in from cardiology, hepatology, endocrinology. Is that something that we can unify throughout the specialities, Ken? Is there that ability to unify on that?
I think so. And the beauty of FIB4 is that it is already in the electronic medical records of most of our doctors. They just don't know it. So education would allow people all over the world, I would say, to calculate this without going to the extra mile and begin then the conversation. Now, for the audience who's not very familiar with NAFLD and maybe listening, Louise mentioned an important aspect that having fat in the liver is a measure of your cardiometabolic health or unhealth, I would say. So the liver is like a mirror of how well you are doing metabolically, whether you're lean or obese. There are lean people or non-obese people that have fat in the liver. And if you look carefully, they're typically insulin resistant or have a family history of type 2 diabetes. We all have patients that have NASH and are not obese. So it's a good reflection of that. And what Louise mentioned is it's also a risk factor for cardiovascular disease. Now, we don't know if it's causative, but it's associated with cardiovascular disease. And this year in June, for the first time ever, the American Heart Association put together the evidence and highlighted to cardiologists how this is a risk factor for cardiovascular disease. So fat in the liver is a cardiometabolic risk factor for heart disease and for the development of diabetes. Now, the FIB-4 focuses on the liver, but it can give you indirectly this additional cardiometabolic information. But from a liver perspective, what we want endocrinologists and primary care doctors is to get good at knowing what is the risk of that person for developing advanced fibrosis and cirrhosis. And by the way, we may also be preventing liver cancer to some extent. So a lot of things in that little test.
Well, actually, I think it's noteworthy that hepatocellular carcinoma is not only linked to cirrhosis, but also to advanced fibrosis as well, right? So you don't have to go all the way to fibrosis to be at risk for liver cancer. That's a good point. Ken, I was going to make a different comment, which is all four of those organizations that you mentioned start with the word American. And when you talk about electronic health records, I think what we in the States tend to forget, although it's come up in at least three of our conversations in this year-end round, and this is only the fourth or this is the fifth, is that Obamacare, whatever anybody in the U.S. thought of it, pretty much mandated and certainly gave tremendous economic benefit to electronic health records. But when we talk to colleagues in Europe, for example, Jörn on an episode recently was talking about the challenges he has because all his results are still in paper, and he gets a patient and he's got to see what's in the paper file and then run over to the fax machine and see what came in, and there's that. And then, frankly, the U.S. may be the only country in the world that automatically puts AST and ALT in a blood panel.
Certainly, Michael Bettel made that comment.
Mike Patel made that comment about Canada. Jörn made that comment about Germany. In the States, for those two reasons, we are way far ahead of the rest of the world in terms of our ability to implement what you're talking about. A question becomes, where do you see leverage? A, what do you see in the rest of the world that maybe we're not? And B, where's the leverage to help those countries come along, and, where would you start? What would your advice be?
Well, that's a good question. And again, I just came from Argentina and actually trained in Argentina, and they include the liver enzymes in the routine chemistries. And a growing number of institutions have their data on electronic medical records, at least in Buenos Aires. So I know this would not be the case in smaller cities. So number one, we hope this with time will change. And before I forget, I mentioned the progress made in the United States, but I have to mention Latin American guidelines had included FIB-4, European guidelines, Asian Pacific guidelines. So although I mentioned the progress we did, many other societies also gone in the same direction before or after. So it's not just an American lead. But how to fix that? I think once there's an awareness of the importance of what Louise said, liver health, liver enzymes are pretty inexpensive, and platelets, CBC, are fairly inexpensive. So if it's not ordered, I don't think that it would be a bad idea to order those liver tests and CBC once a year, which I think is being done. The only difference is if you don't have an electronic medical record, you're going to use a handheld, your phone, to do the calculation. It's hard to answer a worldwide question with so many healthcare systems, but I think, as you may suspect, the first thing is considering liver health priority or a right of every patient, and educating patients that they have to be proactive in taking care of their personal health.
You know what? So we wind up in the same place. The advice we've been giving on the podcast, Mike Patel and Global Liver and everybody else, is it should be a patient advocate priority everywhere in the world to make sure that those measures are taken regularly, particularly for patients who live with diabetes or obesity. Because as been pointed out, if you've got type 2 diabetes, if you live with type 2 diabetes, the question is less likely to be, do you have fatty liver? And the question is more likely to be, has it progressed?
Yeah, I wouldn't be that pessimistic, but they say a pessimist is an optimist well informed. So you might be right, Roger. What I think is that the key is education at all levels, to have strong democracies and to stay healthy, in the sense that if you have obesity, and I know it's many people, we all struggle with weight management, you have to then do the checks and work to see if there are complications. And if you have type 2 diabetes, it's going to be in your hands to go and see your doctor, check your eye checks, do your regular tests. So I think different organizations and different governments have to embrace the concept of care. Now, going back to our listeners, what the listeners can do is there are materials to educate the patient. The clinical care pathways developed, and these guidelines can be easily printed and put in their offices. There are patient health organizations with educational material, and I know, Roger, you've invited several of them over different podcasts. I think patient education will force the doctors to also, help the doctors remember the many, many things that they have to do in each visit.
Ken, do you think it also has to come down to education in medical school and in nursing colleges about the increasing knowledge about these risks? I'm very keen on you assess the person, not the individual diseases, because that just means somebody has multiple hospital appointments through different pathways for multiple parts of a disease process, yet they're the one person. And I know multimorbidity clinics are growing. Do you think that's where we need to be strengthening the education in medical school and all the way through, but also the use and the development of multimorbidity clinics?
Yeah, well, absolutely. So the two questions are, how do you train moving forward? And again, the multidisciplinary clinics. Definitely, when I studied, I remember very vividly that a line that said people with type 2 diabetes usually have fat in the liver. That is part of the disease. And it was a two-liner and no additional comment. I can remember all my career seeing people with fat in the liver and had no relevance. And I still see young doctors who, when they check out a patient we see in clinic, they see it first and I check it out and we discuss the case, that they have people with elevated liver enzyme. What is this? Oh, well, a transaminitis, a little bit of an elevation in liver enzymes. So there's a long way to go. So yes, we need to start early, but until it doesn't reach the cover of our magazines, that is going to take some time. But changes are happening. So I'm very excited. Yesterday, I get a primary care journal, and I was extremely excited that fatty liver was on the cover, and in the inside, there was the AGA clinical care pathway figures. And I was very excited because I was telling my son that I have in pencil, I had written the draft of those with others, and then with Fasika, we worked very hard, and then everybody made their comments. So I was so impressed that now it's in primary care. If you go back to other similar situations, like screening for high cholesterol, or the diabetes, screening with microalbuminuria to prevent chronic kidney disease, I remember primary care doctors listening and asking why, how. So it took a decade to make it happen. So I think we have a long decade ahead of education, but things are going pretty fast now. Back to multidisciplinary teams, yes, and this gets me sad because in the United States, it's very linked to insurance coverage and systems that have to be paid to deliver proper care, and many insurance companies are not vested in doing the best for people, but are driven by greed, I will have to say, and this does not facilitate multidisciplinary teams. But still, we are trying. So I don't know how it is in Australia. Is that any better?
I think most people will say it's bordering on the US system. It's partly Medicaid supported system. So if it's not Medicaid reciprocated, you don't get it. FibroScan is only as part of the healthcare process, and you will only find it in a liver unit, which is one of the things we're trying to change, and with a particular focus in Western Australia. So therefore, I think Australia are leading the figures in liver cancer globally at the highest rate, but they have no figures on liver health. So I think we're a long way, and particularly if we only have to screen 1 in 3 people to find fatty liver. So there's work in the system, but I do agree with you on the American system. It's a lot more electronic record based. It would be relatively a simple leap to be able to scan and screen those records for FIB4s, for ALT raises, for those of common disease diseases where you could pick up high-profile populations. So I think Australia has the potential to go from almost a third world in the way it looks at its liver health to being very much out there and being dynamic very quickly because of the size of the population and the systems that are in place. But will that happen? We don't know. I'd like to keep pushing and levering that, and hopefully with people doing that will be good. There's another aspect. We are looking at healthcare systems around the world collapsing with the amount of patients coming in and workforce shortfall. The one thing for me is to look at preventative care to stop these people coming into hospitals in the future. If we look at wellness rather than illness and look at liver health as that sort of elephant in the room that's never been looked at, the potential to reduce diabetes, heart disease, those related admissions actually looks to support healthcare, because we will never get enough nurses and doctors into the system at the rate population is growing. We don't devise, when we build big blocks of flats, we don't put a new hospital in, we reduce the beds. We do the opposite. We don't put schools in. So for me, being aware and being more preventative and looking at one of the big drivers of some of these diseases or reciprocants of some of those diseases, for me it's a healthcare saving as well as individual saving. We just need to harness the force, I suppose, of liver as our superhero and not see it as the villain in the piece most of the time.
Finally, Jeff Lazarus joins the surfers to discuss a busy but rewarding year in elevating the global public health discussion around fatty liver disease, and also to comment briefly on the nomenclature initiative.
Overall, obviously, it hasn't been a great year for the world. We just did Inside Story for Al Jazeera about the big impending nursing strike in the NHS, strikes in Spain, problems with healthcare, which of course affects us in fatty liver disease. Everyone is overwhelmed. I mean, and we're out of the emergency phase, maybe, or getting out of the emergency phase on COVID-19, but we're still in the middle of a pandemic. In terms of fatty liver disease, I think things have been better. We have new prevalence studies. The data isn't exactly going to make us feel any better with 1 in 3 adults now estimated to have fatty liver disease, but we have stronger studies. We have a better understanding. I think there's been good developments in engaging more with endocrinology. There's been some good reviews on the situation with general practitioners. But really, for me, the big thing is the community's coming more together and also recognizing that the community expands beyond the liver space. It means diabetes, it means obesity, it also means cancer.
So that's interesting, because when I quote you, the line I most often quote is a line from the first time we talked, not even on the podcast, when you said hepatology needs to know they can't go it alone on this one. And I think a large part of 2022 has been about hepatology figuring out, well, they might have known that in the first place, but not having to go it alone.
Yeah, and I fully stand by that. I was a couple of weeks ago at the International Diabetes Federation conference for the first time. I know Jörn was at the European Association for the Study of Diabetes, I think, speaking there for the first time. We're starting to go to their meetings. We need to get them to our meetings. We need to understand the metabolic syndrome and not just our silos. I worked at WHO a long time. Everything was siloed. Even health systems was in a silo, not working with all the different conditions so well. And now we're seeing it again, but we're starting to make inroads to change that. And one of the big, for me, turning points was gathering again for our Wilton Park meeting. That's a think tank based in the UK. And instead of meeting online like we've been doing over the last couple of years, 45 of us were able to meet in person, and we had people from the obesity space, from the liver cancer space, even someone who had helped build a movement in HIV and could talk to us about what it's like, to really build a global movement that's inclusive and transparent and has, I don't want to say clear endpoints, that's too clinical, but certainly clear goals and targets.
Do me a favor then, distinguish, what's the difference between a clear endpoint versus a clear goal and target as defined in this context?
No, I mean, that there's no real difference. I was just kidding, because, we're talking about clinical trials all the time, and endpoints is the language of the clinician. And in public health, we often talk about the sustainable development goals and then concrete targets. In viral hepatitis, we have a goal of elimination of viral hepatitis as a public health threat, and we have specific targets to reach it. So, we have an overall goal on fatty liver disease, right? I mean, we want to end this issue, but we have lots of targets along along the way, more people diagnosed, better treatments, drug approvals, more people adhering to lifestyle structured interventions, and so on.
So I'm going to run with your theme, and I'm going to say that makes sense to me, and that endpoints are only A, one of those, and B, not likely to be met by a single drug, right? I mean, when we talk on the podcast about drugs a lot, we talk about the idea that over time therapy will evolve into something that looks a little more like drug therapy, will evolve into something that looks a little more like cancer with induction and maintenance, that there will not be one-size-fits-all treatment, but that because different patients present with different sets of issues, you'll need different kinds of medications, and you'll need some sophistication about how to use them. And that going back to where you started, we will also have the issue of you can't possibly get all this done in hepatology. So we're going to need the feeder system to work a lot better.
That's absolutely right. And, we can look to COVID that everyone, has lived experience with now. It wasn't enough to just vaccinate. The top priorities coming out of our paper, in the Lancet, in the Nature was, a vaccines plus approach. Vaccines may be the cornerstone, the same way maybe drug therapy will be the cornerstone for fatty liver disease, but we're still going to need to improve lifestyles, diet, and exercise. We're going to need general practitioners and nurses and nutritionists and dietitians to help and support adherence. This can't all be done from the hepatologist's office. And really, I guess the best comparison is to viral hepatitis. It moved out of hepatology into infectious diseases, into addiction centers. In Australia, it's even out of the GP office, prescribing DAAs and overseeing adherence. It's still in hepatology as well, but it will need to expand. And that goes back to what we both said about this is not an issue for hepatology alone, even if hepatology can lead.
You had Barcelona early in the year, and then Wilton Park in October. And where do you see that part of the effort coming forward in 2023? What do you see as the major accomplishments for 2022 beyond just getting people together, which is not trivial? And then where do you see it leading in 2023?
Yeah, so the Innovations in NAFLD Care meeting was a bit unique. You were there, so was Louise. It was a small group, but it included endocrinologists. It included people from, a few people from outside the liver space, but really thinking and, co-creating together what we need to do. So we will meet again, but it's not just about meetings. We won't necessarily have another Wilton Park meeting. We need to meet where there already are meetings. That's one thing we learned during the pandemic. We need to cut down on our travel. We will cut down on some, unfortunately, I think, on some of our face-to-face time, but for a lot of reasons that makes good sense. But now we need joint documents. We need to make that roadmap together. What does it mean for the world? There's no WHO strategy. There's no WHO action plan. There's no technical guidance. So there's a lot to do. Doesn't mean that there's no technical guidance out there, right? Professional societies have clinical care guidelines, but WHO needs to have their technical guidelines. Whenever, I've said this over and over, whenever they did this recently, publish their NCD technical guidance, there's no mention of the liver except to deliver on diabetes care and to deliver on cardiovascular disease care and so on. And it's not a competition, but you're not doing anyone, patients or people at risk, a service if you're not also mentioning the role of liver health. You're not providing, I would say, full and good care for people with diabetes if they're not aware that they're at risk of and actually have a very high likelihood of having liver fibrosis. So one of the things we discussed at International Diabetes Federation, the big diabetes conference, was people asked them, well, why in endocrinology should we even be testing people for fatty liver disease if there's nothing we can do? Well, there's a lot we can do, even without a specific NAFLD drug. There's actually a lot of drugs we are providing. We're getting their diabetes under control helps, and it can help people adhere to their diabetes medicine even better and take it even more seriously if they realize also their liver is at risk, also their heart is at risk, and so on. So, for 2023, it's about, consolidating more. It's getting that roadmap started. And one of the big projects we have is a research and action agenda. So a large group of almost 500 people from over 100 countries weighing in on what are the priorities in research and what are the priorities in action. This is just be a guidance document. You can still do whatever you want, but at least we'll kind of get ourselves on the same page the way we did with the NAFLD public health consensus statement to say, actually, this is a public health issue and a liver issue.
I think Jeff's been absolutely key in everything he's said. 2022 has been probably the biggest year that I've seen and continues to deliver on associated metabolic conditions coming to the table. We did a catch-up with Naeem earlier on in the week, and he was saying when he assessed the AGA guidelines for NAFLD that only 9 to 11% of people need to be seen by hepatologists. I've commented before that most people have poor liver health. They don't have liver disease. So this whole thing about we only need to see what we need to see. But the American Association of Diabetes yesterday published their standards of care, and section 4 is all about screening for NAFLD now. So earlier on in the year, in May, the American Association of Heart Disease acknowledged that NAFLD needs to be screened for, and it increases mortality in their population. So we have the big players now starting to recognise NAFLD and NASH as a real serious complication, co-founder and comorbid condition to theirs. And I think this is where we will start to move. So we need to have that real three-pronged development of all of the associations moving forward. And obesity, whilst the WHO themselves don't have an NCD for fatty liver disease, they did in the European obesity strategy say that NAFLD was the fastest growing non-communicable disease in obesity. So they have used the term. Let's get them to define the term going forward. The NAFLD strategy meeting in Barcelona was key, bringing some of those players together with the patient associations and Donna, because I genuinely get a sense of movement this year in that way. And that's great.
You mentioned, Louise, the AGA guidance, and of course that was published in gastroenterology. I believe it was also published in obesity and simultaneously in diabetes care and simultaneously in metabolism. So, these are signals to the members of these societies that this is for them too. In this day and age, you get a PDF and you look at the journal, but you don't just think about where it was published. But if it's your society journal, you pay particular attention. And the fact that this was published, in sort of 4 society journals is we haven't really seen anything like that in a long time. So the field is moving in that way. And like you mentioned, in Barcelona, a priority was to engage with the patients, with the community, and that's a big community. That means bringing diabetes, cancer, and obesity to the table. The things we did at Wilton Park, and I'm on the Public Health and Policy Committee at EASL, and it's also a priority for EASL now to engage more with the patients as well as the patient advocacy groups and really hear from them. And that's why last year you featured it, I know, on Surfing NASH, the patient guidelines we developed led by Sven Frank and others. And it's been great to see them being used and translated in a short version and the images and so on.
So convergence takes many forms. And one of the things I thought was interesting in the past year that we've never formally commented on this podcast was the formal alliance of the Fatty Liver Alliance of Canada and the European Liver Patients Association, right? Because you've now got organizations reaching across the pond and saying, we are patients wherever we are have the same issues. We have similar comorbidities. We have similar needs to deal with government and sustainable goals and those kinds of things. And therefore, we should all be aligned. I'm not aware of that happening in a lot of other diseases. I know they're international groups, but where national groups from different, not even the same continent, reach out to say, okay, we are one here. I thought that was kind of an interesting thing.
It's a great development. It's where the field needs to move. There's so many learnings they can share. Of course, that came after ELPA split into LPI and ELPA. I'd like to see a movement where people are working back together again. In hepatitis, the World Hepatitis Alliance grew out of what was back then ELPA and brings together representatives of national organizations from all over the world who then have regional representatives, and you can still work at the national level exactly the way you want to, but you have a forum to engage, and they have a nice conference, but they also have a lot of other things. So they work together on World Hepatitis Day, they report patient stories, they've collaborated on the Lancet Commission, bringing the patient voice. So the more we can see that kind of collaboration of patient groups, and if they can start to bring in diabetes and cancer and obesity in one way or another, formally or informally, I think it will be a huge advance for the field.
I was thinking exactly the same thing there with Jeff on the charities and the patient groups, is the fact that the word liver, again, in the diabetes or cholesterol or heart disease foundations, anything on the website, the only word that contains it is deliverance. So maybe we now have to ask their society heads to start publicising, because if a patient presents to their practitioner, whether it's their endocrinologist or whether it's their primary care physician or even their primary care nurse or diabetes nurse, and says, I've now been told or I've noticed on the website that they're asking for the screening for my liver, how do I go about that? Then we might start to again get get the huge patient involvement, because I think a couple of years ago, if I'm correct, pancreatic and liver cancer took over vascular disease as the biggest comorbid condition in type 2 diabetes. And I think there's been very little focus on that within those areas. And having recently been out in Australia, they've got some great material, all on diet and nutrition, but the liver is excluded from absolutely everything. So it's somewhere we can look to strengthen.
Yeah, I mean, last year we coined, to deliver on the liver and have a project with that name. And yeah, it's a little corny, but it's exactly what we need to do. We need to deliver on the liver. We need WHO to start delivering on another condition. So it's great that they mentioned it once, but they should be mentioning it hundreds, if not thousands of times. Because I really do believe, what the EASL-Lancet Commission said, the liver is sort of a window onto society. And that's why we were developing that work around the Sustainable Development Goals and showing the connection between different goals and targets to the liver. Because if your liver is failing, it means you can really see how society's failing. Maybe there's not places for you to exercise. There's not safe, urban, green environments. You don't have good food accessible. And I was in this debate the other day and someone said, it's personal choice. And I said, it's not always choice if you don't have enough money. And someone in Spain was giving this data on a study in New York and Madrid, and it was fascinating. In the poorest areas of these cities, you have the highest concentration of shops selling the worst quality, right? The ultra-processed food closest to the schools. So the first place these kids come out in the poorest areas, the places that have the worst food. So it's not always about individual decision-making. There are structural things we can do. And one of the ways they decided to resolve it was they're not going to go in and close the shops, but they said no new shops selling that kind of food can be built within a certain radius of the school. And I think we need to be thinking out of the box. And anyway, the liver really shows us how society is not working for the most marginalized populations, for the poorest populations, and in so many other ways, because it's not just poor and marginalized populations who have liver problems or fatty liver disease.
Reminding me of the old idea from business school that people do what's inspected, not what's expected. We've had challenges with how do you inspect the liver? And then in the conventional medical sense, we've had challenges with what do you do about it? So I'd like to spend a couple of minutes looking at those from your perspective. Let's do the inspect first. The rise in non-invasive testing and work on ways to use non-invasive testing, particularly liquid biopsies and FIB4, which has its limitations but is cheap. How important and how do you think that gets put to best purpose in pursuit of the kinds of things we're talking about here?
It's an absolute game changer. And I think most hepatologists would tell you they're really only doing liver biopsies when they absolutely have to, or, which includes clinical trials. But I would take a step back first. So what gets inspected, we don't have surveillance. When WHO started doing disease surveillance for HIV, for TB or malaria, and countries had to report and countries were compared, that's what I was referring to really in my first comment about the good news is we have prevalence data. It means there was enough studies for Dr. Younasi and for others to carry out these kinds of meta-analyses and tell us what's going on. Of course, the bad news was what we found out was that so many people have fatty liver disease, but we actually are getting more and more studies. So we do need that kind of inspection. In this case, I'd call it, monitoring and surveillance. Now, in terms of, individuals, the rise of NITs in our real-world study in JHEP reports recently, just 35 participants reported using 14 different NITs with transient elastography and FIB4 being used most. And that's not a problem that they're using many different ones. I hope they're using them sequentially. I hope they're using some of them at the same time, because no one said, with a FIB4, you're making a definitive diagnosis. It means now you need to move quickly to the next test. But like you said, it's cheap. It's a calculator. It still takes some time to do, but we should be doing this in every person with diabetes, I think really in primary care throughout. And I know EASL and AASLD have different views on are we going to be testing risk populations or not, and what's cost effective. But given the numbers now of how many people have fibrosis, advanced fibrosis, and cirrhosis in the general population, I think we need to be getting much better at testing for it. And we need to raise awareness. And we need to, a couple of years ago, we were saying, the tsunami of everyone ending up in hepatology. Well, we deal with that with better risk stratification. A lot of these people are in care anyway, right? An estimated 55% of people with diabetes type 2 will have fatty liver disease. So they're in care. They don't necessarily need to go to hepatology, but they do need to be monitored. And NITs aren't well studied for, let's say, disease prognosis, but they will give us a lot of information. And we need to really roll out portable fibroscans and a better understanding of what NITs are available, what their costs are, how to use them.
So, Jeff, Jeff, the other question, of course, is you now have Intercept refiling OCA with FDA, and Madrigal, I now will file resmetirom as quickly as possible. They announced that this morning when they released their data. How do you see the advent of meds, specifically targeted fatty liver medications, affect the processes that we're talking about here? I mean, it's clear what happens once you get patient in a hepatology office, but how do you think it affects everybody else in the treatment chain and in the disease chain?
I think it'll be just like what happened with HIV and DAAs. Because remember, when HIV was available in high-income countries, it wasn't in low-income countries and most middle-income countries. And as it became available, we saw more people being diagnosed. We saw awareness going up. We saw models of care changing, being developed. So you mentioned, we published an expert recommendation on models of care in Nature Reviews GastroHep in 2021, but we did one on HIV in 2010, showing new models of care for antiretroviral therapy. So as we get the new drugs available, there'll be new models of care. There'll be people more interested. Like I said, at the diabetes conference, when they hear that there's a drug, so for them, that means there's something can be done, they'll be more interested in it. What we need to do is make sure, and we'll really need the patient groups helping us, that doctors and clinicians are aware that actually you need to do a lot more than the drugs. There'll be a crucial role for nutritionists and dietitians, I think for GPs as well, because all of these people won't be able to be seen in hepatology. We'll need new collaborations like we had with suddenly GP prescribers of DAAs or nephrologists trying to eliminate hepatitis C in their nephrology department. We're going to need to be thinking, what are the new models of care? How do we improve communication? What does teamwork and multidisciplinarity look like? And we're moving in that direction, but incredibly slowly. The availability of drugs and the almost availability of drugs will really set fire to the changes that will need to come. So I think the Madrigal news and hopefully an approval of OCA, even if they're not widely available and even if they take a while to get approved, that news means that we need to start moving now and be prepared so that in a couple of years we're set. And that also means addressing the policy arena, making sure that policymakers, health authorities are aware that there's a potentially deadly condition that's highly prevalent and that there's a drug either about to be approved or that is approved, but the majority of people are undiagnosed.
Please join us again on Thursday, December 29th, when Stephen Harrison, Naeem Alkhouri, and Ian Rowe join Jörn, Louise, and Roger to discuss their own perspectives on 2022 in fatty liver disease on the final special year-end episode of Surfing the NASH Tsunami.